We're just rethinking how we can best use stewardship to decrease C. diff. So I went over 5 strategies, one of which we may have already spoken about, which relates to appropriately testing patients, making sure the right patients are tested and that they're tested in a timely fashion. There are strategies for basically picking what antibiotics that you have on your formulary, making sure that they may not necessarily predispose your patients to C. diff. Also, for some new drugs that are used for treatment of C. diff, making sure that we steward these properly so that we have them when we can use them. Optimizing the treatment for C. diff so that that one patient can be treated, but also decreasing C. diff in that patient may make it less likely that they're going to transmit to other patients. And then lastly, really reviewing the medications at different points in the patient's course, looking at antibiotics before someone gets C. diff, and then also looking at antibiotics and other medications that may be given after someone has C. diff, trying to basically make it such that they'll be more likely to really recover from the C. diff, which is good for them and also good for the patients near them so it isn't transmitted for them. So I would say that we really underscored 5 large areas where people can really have impact with stewardship and C. diff, which include optimizing the testing, optimizing your formulary, optimizing your treatment, optimizing the antibiotic choices before, and reviewing antibiotics and other medications after. And then really bringing it all together, that stewardship is not really something that you would just do in a vacuum, that this is really part of a larger strategy, that C. diff is really something multifactorial. It may come in your door on a patient. It may be that the patients need to be isolated, could be transmitted within patients, or there may be things on the environment. Or do we breed C. diff in patients by giving them too many antibiotics or other medications? And so really, we can't just have one strategy. Likely we're going to need to do all these things, and luckily ASP is really often a very good complement to these usual strategies, and that hopefully we do all of these and we're really able to combat C. diff. Just to sort of bring it down to a home level, that this is a very tangible outcome for physicians to see in terms of overuse of antibiotics, and that we're not going to decrease all our antibiotic prescribing. This is not, let's say, a never event like a line infection or a urinary tract infection. There are patients that really need antibiotics. What we're trying to do is make sure that patients get appropriate antibiotics and that we don't overuse them, and that maybe we strike that balance where they're able to treat the infection that is needed but not kill the rest of the good flora on them, which is really protecting them from C. diff. So I think we have amazing opportunities, and that the thing is that we don't certainly want people to get C. diff in our institutions, that stewardship offers many strategies along the way to really hopefully prevent patients from getting C. diff and prevent it from being transmitted to other patients in the environment.